So the first thing I want to talk about is what we're going to do tonight. Whenever we talk, it's always important to know kind of where we're headed. So our objectives tonight are we're going to talk about your anatomy, because one of the problems or things that we see all the time is that people really don't know where their parts are or what their parts, the purpose of their parts. And so we're going to talk about that. We're going to talk about the causes for pain. Also, why do you see a healthcare provider for these symptoms? And then what are the treatment options for pain or these symptoms that we're talking about? So why do I have pain? That's often a question when individuals come in, what's going on? So it's really important for us to thoroughly evaluate you to figure out that underlying cause. I think all three of us talk to our patients about educating them, providing you with knowledge, and empowering you to come up with a plan that's going to best suit your needs. When we talk about pain, it can be pain with intimacy or with sexual activity. It can be just doing cleansing or personal care. It can also be in relationship to passing your urine or moving your bowels. The way I think about it, and I think I can speak for Felicia and Natalia also, is that these types of symptoms or situations or disease processes are often best treated when you have a multidisciplinary team approach. So the first thing we're going to do is we're going to talk about anatomy. If you don't know your anatomy, it's really hard to understand some of the treatment plans. So we're all going to talk about about the anatomy. So like I said, I'm going to start with female anatomy, and so many women, when they come in to see me, have no idea where the clitoris is, what are the labia. So we want to understand those parts. So first and foremost, when you come to the gynecologist and you assume your very favorite position, this is what we're looking at. So from the top down, you can see what's called the mons or the pubis, and that's that area that the laser is pointing to. Down below that is your clitoris, okay? And that clitoris can have 5,000 nerves that go to that area, so it can be very sensitive. There's an area above that called the prepuce, or we call it the hood a lot of times of the clitoris, that provides protection. You have labia majora. Those are the larger labia that are further on the outside. And then you have labia minora, or the smaller inner labia, all right? And then from right above or right in between that area is what's called the vestibule. And so that vestibule area also has a lot of nerves and can be very sensitive. Then you have your urethra, which is where the urine comes out. That's that passageway, the urethra. Then you have your vagina. And when we talk about the vagina and we're evaluating patients, what we do is we look at the opening of the vagina and then inside the vagina and what's going on there. There's a tissue there called the perineum, or the perineal body, and that's the area between the vagina and the anus. And that length of that can change dramatically, especially with childbirth and changes in your tissues. And then the final area is the anus in the female, all right? When we're looking at anatomy, it's important to understand all of those things, because when we talk about teaching and different things, it might be medication or exercises. It's really important to understand those areas.
All right, so I'm going to speak a little bit more about the pelvic floor anatomy from a musculoskeletal standpoint. So your pelvic floor muscles are not visible, and you may be unaware of their existence, but they serve a very important purpose. So there's 3 layers of muscles in the pelvic floor, and your pelvic floor is like a bowl, which you can kind of see here in this picture. And the muscles sling back front to back, almost like a hammock, to support the bladder, the uterus, and the rectum, as well as the prostate in males. The function of the pelvic floor is to maintain continence of feces and urine, allows voiding, it supports the internal organs. There's a sexual function, and also another important note is that your pelvic floor and your breathing muscle, or your diaphragm, which sits underneath your rib cage, work directly together like a pump system. So I want to do a little example with everybody. So if everybody is in a seated position and you take your fingertips and you find your sit bones, so right underneath your butt cheeks, give you a second to do that. So your fingertips should be pressing into the pelvic floor muscles right now. And I want you to just take a big breath in and exhale and see if you can feel some slight movement of those pelvic floor muscles into your fingertips and away from your fingertips. Take a second. All right, now I want you to take a big breath in, but when you exhale, I want you to pull your belly button towards your spine and hold your breath. When you do this, did you feel a bulge into your fingers? If you felt a bulge, this is an example of incoordination between your breathing muscles and your pelvic floor. And this can cause a lot of downward pressure onto the pelvic floor muscles, which can eventually lead to dysfunction down the line. All right, so now we're going to talk about male anatomy. So a male pelvic floor has some minor differences when compared to females. So the male pelvis is taller and more narrow than females. They have an extra muscle starting from their abdominal tissue that suspends the testicles. There's only 2 openings in males versus 3 for females. Very similar function to females. And then this is one of our models that we use here for our male patients. So here we can see the bladder. The prostate would be right here underneath the bladder. The rectum sits back here. And then we can see the urethra running from the bladder through the penis. And this is just a detailed chart of the male anatomy and the function for your reference.
So when we talk about your team, in the beginning, I said that there's a multidisciplinary program that we're all working together. So your healthcare provider, when you talk about from that medical evaluation of any underlying cause not related to muscles necessarily, it could be a physician, a nurse practitioner, or a physician assistant. The whole idea of that when we're meeting with you is to rule out, to identify and treat any of those medical causes for your pain. We also, at least I do in my office, and the nurse practitioner and physicians I work with also do look at those vaginal muscles and do that vaginal exam or rectal exam, depending on what's going on. And then your pelvic floor physical therapist, they're going to evaluate and treat those structures related to pelvic anatomy. So we're talking, as Natalia talked about it, it's more than just those muscles that go from the pubic bone to the tailbone, but your hips, your abdominal, your breathing, all of those things are going to interact. So that's why it's so important to kind of look at all of these areas. So what happens next? You decided that you have an issue and you're going to come in and you're going to see first your healthcare provider. When you come in to see us, as I said in the beginning, and I feel like I sometimes beat a dead horse, is that we have kind of 3 jobs. Our job is, I call it the bladder, bowel, and pelvic health detective. So our job is to try to help identify the cause of the problem. We're going to do a detailed history, and you're going to see with physical therapy and the healthcare provider, a lot of this overlaps. We're asking a lot of the same questions. We do an exam, and sometimes there's testing that need to be done. And then based on that, we're going to come up with a plan that's going to best suit your needs. It's also really important to understand when you come in to see someone like myself, there's going to be 2 really important questions that I ask. What's your chief complaint? So what brings you in to see me? And what's your goal? Because it's very important that I may find other things going on that aren't an issue for you. You might come in with pain with sex, but you have a little bit of leakage of urine, but your goal is really to identify those issues with the pain with sex. However, I still will educate you about your bladder stuff, things too. So first things first, we're going to look at your history. We're going to look at your past medical history. Have you had surgeries? What medications are you on? Kind of what other treatments, providers have you seen for these symptoms? We're going to look at your medication. But it's really one of the things that always confuse patients when they come in to see me. Say you're coming in with pain with sex and you're a female patient. You're thinking I'm only going to ask you about your vaginal symptoms or what's going on in the vagina. But you have to understand that your urinary function and your bowel function, all of those are interrelated. So when you come in to see us, we're going to ask all of those questions. Okay. So one of the things, after we ask all the questions and go through the history, we are going to do a physical exam. A couple of things that we look at, we may do a urine specimen to make sure that there's not a urinary tract infection or that you don't have blood in the urine. We're going to look at that external tissue. If you go back on that picture we saw in the beginning of the labia, whether it's the labia majora, the minora, the urethra, the vagina, we are going to look at that external tissue. We're going to look for any irritation, any discharge, any lesions that are there. We also touch that area with a little Q-tip to make sure that there's no areas of specific tenderness. We do a vaginal exam. One for two things. We're looking for any changes in the walls of the vagina. There can be relaxation of the walls of the vagina called prolapse. And I know Natalia and Felicia are going to talk a little bit more about that a little bit later. We're looking at the integrity of the vaginal tissue, and we'll talk about that a little bit more. We look at muscle function. So I always call myself the beginner muscle function tester. So when you come to see me, I'm going to look at your muscles. I'm going to teach you some pelvic muscle exercises. I may be teaching you how to relax those muscles until you never do a Kegel because your muscles are too tight. But I'll do that initial testing and evaluation, but then I send you to the muscle experts, the physical therapists, that will do a little bit more or a lot more with all of those other muscles, including your pelvic muscle. We are going to evaluate that pelvic muscle function, both the superficial muscles and the deep muscles, and they're going to explain that in a little bit more detail. If you come in with bowel issues, constipation, pain in the rectum, I will do a rectal exam, and that's everybody's favorite because they always tell me things are supposed to go out of there, not go in, but we can't figure out what's going on if we don't do an exam. And sometimes we'll even do swabs to rule out infections. So what's the result of all of this? So the result is to come up with some diagnosis, and sometimes there might be multiple diagnoses, and what's the plan of care? But what I want to interject before here is that education is going to happen at this, either before we do your history or after your history and exam, depending on what you're coming in for. By the time you leave my office, you'll have already seen those beautiful pictures of your vulva, maybe your own vulva, depending on what's going on, or it could be of the images that I have in the office. We're going to go over exactly what's going on with you and what the options of plan are, or the options of care. So it's really important to understand that you're an active participant when we talk about evaluating pelvic pain and moving forward. So some of the more medically related causes where we're not talking about pelvic pain that can cause pelvic pain or pain in both the vaginal area, externally, pain with sex. So first, let's talk about some inflammation. Inflammation is the a redness and irritation, swelling in an area. So there are definitely things that are reversible. So first thing I'm going to teach all of you women that you're going to be shocked to know is that there are contact irritants. Always pads. If there's anything you walk away from that you can share with your friends and yourself, are to not use always pads. They can really cause a lot of irritation of that vulvar tissue. And you say, but Kathie, I'm having pain with sex. What does that have to do with it? Well, remember, if the vestibule or the entranceway to the vagina is causing you pain, it's going to be a lot more difficult to have intimacy without any pain. Detergents can be irritating. Types of underwear. So you want to use free and clear detergents. You want to use, everybody's favorite detergent when they come in to see me is Tide, regular Tide. And I always say, just remember, watch those commercials where the enzymes get rid of all of the stains. Well, unfortunately, most of our machines don't get all that soap off, and those enzymes can really be irritating that vulvar tissue. So those are things that I always say are the keep it simple, stupid things. Take care of those. That may make a big difference. Urinary incontinence is definitely a treatable thing that can cause inflammation. If you're wearing a pad, you're having, and that moisture is there, sometimes that can cause inflammation and discomfort around the opening of the vagina. There are also other chronic inflammatory processes that can go on that can actually cause structural changes of that external tissue. There's something called lichen sclerosis or lichen planus. And I feel like it's one of the things, when I first started practice, I was told it's very rare. And I have to tell you, in my practice now, it's not a rare occurrence. There are changes that can be visible changes that we see in that vulvar vestibule area. The tissue can be white. You may not have any changes in color. It might just be burning and itching. Some women come in and they complain about incontinence or pain with sex or something else. And when I look at their tissue, I see these visual changes. And we can make a significant change in all of that, in that tissue, in that discomfort, that pain with sex, just by addressing those symptoms. The only way really to know that is to come into the office to have an exam. Sometimes we do a biopsy, but the guidelines really are now that you can treat it first. If there's no changes, then we do a biopsy, but you can come in and we can treat that. I had a woman this morning who came in that was suffering from terrible itching and burning and discomfort. And she's been using medicine for about a month and it's amazing. She's like, it's 95% better. So again, a lot of things are very treatable. Infections. So many women don't understand that they can have an infection that is a yeast infection. You expect to have all that discharge and itching. Well, some women don't have any itching or discharge, but they have pain with intercourse. And what we find is they have yeast, and it may be an abnormal, not an abnormal, but a different type of yeast than the typical Candida albicans. So we check for that. Sexually transmitted infections can cause urinary symptoms, can cause pain with urination, can cause pain in the vagina to some extent, but it's more related to the urethra and the discharge. You can also have a bacterial infection. Some women can have both recurrent yeast and bacterial infections. And with that happening, if you can imagine what's going on is there's irritation in the vagina. That vagina can be all red and inflamed and cause issues there. Changes in estrogen. So yes, you see my desert there. I have some women who come in and say my vagina is as dry as the desert. And so that's why I want to use this beautiful slide of the desert. When we talk about changes in estrogen, it's can be from birth control. A lot of young women don't realize that birth controls keep those estrogens at a much lower level and can cause some dryness and pain with sexual activity. But menopause in general is the big culprit here when we talk about some of the changes and pain with intercourse. So I apologize that this slide is a little blurry, but I think it's the most beautiful representation of some of the things that happen to our vagina when we go through menopause. What I tell women when you come in to see me, that 80% of women after menopause within 6 to 8 years will have some of these changes of genitourinary syndrome of menopause. It's just a big word to state that there are changes in both the urinary system and the vaginal genitourinary system from menopause. So the average age of menopause is 52, but some of these menopausal changes can begin to occur prior to actual menopause. And so we want to try to address these. So I don't want to send you to physical therapy if your vagina is having all of these other issues that they might not even be able to do an exam to see what's going on. So if you're looking at the slide here, on the left-hand side is a vagina that is not postmenopausal. You can see there's those little ridges in the vagina. What's nice about that is that gives that vagina some elasticity. Those are called rugal folds, and they can actually help expand the vagina. If you look at the length of the vagina, you lose a portion after menopause. Well, let me go to the folds. If you look to the side of the vagina where it's postmenopausal, you can see it's very thin. There's not that elasticity. And so if you can imagine with sexual activity, when you have that non-menopausal vagina, it stretches, it gives. On the other side, there's less flexibility, less elasticity, and there's thinning of the vaginal walls. There's also what's kind of amazing that there's a shortening in the vaginal length. And so especially for women that have had maybe a hysterectomy and may not have been sexually active for a while and then go to be sexually active, they may notice some real changes. The opening of the vagina can also narrow. So sometimes there's enough elasticity or space in the kind of the canal of the vagina, but at the opening of the vagina, you can have narrowing. And with that, then it's much more difficult to get anything into the vagina. So it's very important that we address that. When we talk about genitourinary syndrome of menopause, we can start with simple things, just a lubricant for sexual activity and maybe a remoisturizer. If those things don't work, we can move on to interventions such as estrogen cream. And it is the most, I have so many patients who call it the miracle drug. The magic cream is what they call it. And so it actually can make that tissue much more elastic, reduced pain. We can do things like dilation, and both myself and the physical therapist do dilation to help work and expand that tissue once that tissues that are estrogenized. In addition, there's something called Mona Lisa Touch, which is a laser therapy. So for women who are apprehensive about using any topical estrogen cream, we can do something called Mona Lisa Touch. And that can make a huge difference. It's a revitalization of the vaginal tissue and the tissue of the vulvar area. And that's something that we also provide or do at our Center for Incontinence and Pelvic Health. So as you see, these hormonal changes that occur, we need to address those before we, or at the same time that we're addressing muscle issues. There's also something called painful bladder syndrome. And this is individuals that come in and often they have frequency and urgency to go to the bathroom, but in addition, they can have pain with sex, or sex actually causes that pain in the bladder or discomfort in the bladder. This can happen in both males and females. I know I've kind of focused primarily on females, but Felicia and Natalia are going to talk a little bit more about the male patients. But both males and females can have painful bladder syndrome. That can be frequency, urgency, pain with your bladder filling, pain with emptying, pain with intimacy. And a lot of individuals that have painful bladder syndrome or pain with intimacy actually have pelvic muscles that are too tight and too tense. And that has to do with some of those changes that occur with that constant sense of needing to go to the bathroom. The other thing we address is prolapse, but I know that Felicia and Natalia have a lot of pictures in there and I can always interject a little bit, but instead of us both talking about it, I'm gonna be quiet and let them talk about things now.
Okay, now that you're overwhelmed with all that great information with Kathie, we're gonna overwhelm you even more with some specific things about pelvic floor physical therapy. So the exact definition for pelvic floor physical therapy is a non-surgical approach to rehab of dysfunctions in the pelvis that contribute to bowel, bladder, sexual health, and pain complaints. So you'll see a list of bulleted points here, and I'm going to give you some examples of each because these are the things that we tend to focus on when you come in for pelvic floor physical therapy. So some examples for behavioral can be toileting habits, avoiding schedule, water intake. For manual, we do a variety of different muscle releases. For modalities, we can do things such as heat, ice, electrical stimulation, kinesiology tape, different biofeedbacks. For exercise, we focus on some core and hip strengthening as well as mobility. We can focus on Kegels and different breathing patterns. Education, we can focus on anatomy and physiology of the pelvic floor muscles. Again, toileting habits, bladder habits, and we tend to focus a lot on movements such as squats. Okay, so kind of overlapping a little bit with what Kathie said in terms of history, at your first eval with us, we tend to set aside about 90 minutes. You'll have one-on-one with one of your therapists. So here we have 3 pelvic floor therapists. We're very lucky to have more than one. We will extensively kind of look at your past medical history, chief complaints, and then we will assess your musculoskeletal system. So looking at your anatomy, muscle function, joint mobility, nerve innervation, etc. We'll also take a look at your posture, breathing, range of motion, strength, palpate a variety of muscles to get a better idea of any impairments that might be going on. Similar to how Kathie had mentioned, you might come in with one chief complaint, and sometimes we find some other things that are going on. You might notice you have, urinary incontinence or fecal incontinence when you think you're having just pelvic pain. So those are things that we will address as well. We typically, after we externally take a look, we do a pelvic exam as well, if indicated. Same thing like Kathie said, we will do a vaginal or a rectal exam if it's indicated, and we're going to kind of dive a little bit deeper into that in the next slide. But our main goal is to educate and empower you to take an active role in your healing starting day one. So starting at your initial evaluation, we're going to give you things to start that process and your journey. And similar as well as Kathie said, we will create a plan of care that works specifically for you. We'll have visits following, and then we'll kind of reassess as appropriate from there.
All right, so I'm going to take over what a pelvic floor assessment looks like. So I know there can be some misconceptions of what a pelvic floor assessment consists of. So I just want to clear those up. We do not use any tools or speculums to assess the tissue, just one gloved finger.
We do.
From a physical therapy standpoint, we don't.
Right. I was just kidding.
The exam can be performed vaginally or rectally based on your symptoms, as well as the clinical judgment of your provider. A pelvic floor assessment gives us important information on how to guide your plan of care moving forward. For example, we want to figure out if your pelvic floor muscles are tight or weak and what the range of motion of that tissue is. So for example, someone with a tight pelvic floor can still have urinary leakage, but someone who has urinary leakage may think that they have to strengthen the pelvic floor with Kegels. But if we strengthen a tight pelvic floor, that's only going to lead to further dysfunction, making the leakage a little bit worse. So I want everyone to hold their hand out, palm open, and then close your hand into a fist. So think of that as your pelvic floor's full range of motion, so open to close. Now I want you to squeeze your hand into a tight fist. And then if I asked you to make that fist a little bit tighter from here, your muscles have a very hard time contracting because they're stuck at that end of their range of motion. So this can lead to weakness, and continuing to pump these hand muscles or your pelvic floor muscles to strengthen them would only tire out those muscles more and more and cause pain. So back to the pelvic floor assessment. So we can look at the muscles externally first. So we're going to look at muscle and skin integrity. We're going to look at the range of motion of your pelvic floor tissue. So if you were going to physical therapy for your shoulder, your physical therapist would have you move your arm in all different directions to see how that joint is moving, where those muscles are moving. We'll do the same thing by asking you to bear down, as well as to do a pelvic floor contraction. We can look at involuntary muscle movement through coughing. We're going to look for any scarring and skin integrity. We can test sensation, which we do through a gentle touch of a Q-tip. And then we can look at muscle integrity, which is performed through external palpation of the external muscles with one gloved finger. And then if all goes okay and everyone's still feeling okay during the examination, we can proceed to the internal portion. So here we're going to look for prolapse or any downward descent of the pelvic floor organs. We can palpate the deeper layers of muscles for any reproduction of pain or symptoms that you may be having. And then we're going to assess the coordination between all three layers of the pelvic floor tissue. And then we're going to examine your strength and the endurance of that strength as well.
Okay. And so this is a slide that has a list of a variety of big terms. You might see these both when you're in the office with Kathie. You might see them as well with us if you're here for physical therapy. I'm going to kind of give you a brief definition of each one because some of these terms can be kind of intimidating. So vulvodynia is pain around the vaginal opening. Coccydynia is tailbone pain. Chronic UTIs, which are just recurrent urinary tract infections. Dyspareunia, painful sexual intercourse. Vaginismus, involuntary tightening of the vaginal musculature during penetration. Prostatidynia, which is pain around the prostate. Prostatitis is inflammation of the prostate. Postpartum tearing typically tends to be around the perineal area, which we talked about a little bit earlier, that space between the vagina and the rectum. Prolapse, which we keep touching base on, can be a cystocele, which is a bladder drop. It can be a rectocele, which is when the rectum can bulge into the vagina or the uterus. We can treat post-surgical, which can be any kind of pelvic floor muscle surgery, which includes gender affirmation surgeries. Endometriosis, which is a painful condition when the uterine tissue grows outside of the uterus. And painful menstruation, pain during your menstrual cycle. So some of these terms you might be talking about when you're with Kathie if she's going through and making sure medically all this is kind of being taken care of, some of the interventions that she talked about already, and then we can do some different interventions as well that we're going to kind of dive a little bit deeper into. So we're going to touch base on a couple specific topics just to give you an idea of some treatments. we'll kind of all tag team in to discuss some of those.
All right, so the first one is dyspareunia, vaginismus, and vulvodynia. So dyspareunia is a common sexual dysfunction. And according to a study published in 2019, 8 to 21% of women experience recurrent genital pain either before, during, or after vaginal penetration. These conditions can occur from injury during vaginal delivery, pelvic inflammatory disease, infection, adhesions, sexual abuse, and other psychological factors like anxiety and depression. Because of the multifactorial etiology, a multidisciplinary approach, which Kathie had emphasized in the beginning of our presentation, is so important when treating these conditions. So the musculoskeletal system plays a huge factor in these conditions. So modifying the tone of the pelvic floor muscles is an effective way to treat these conditions. So pelvic floor PTs can perform various manual techniques like myofascial release, intravaginal massage, trigger point release of the muscles internally, as well as surrounding muscles in the back, the glutes, the hips, and the abdomen. Manual techniques, as well as breathing techniques, can improve the awareness of the patient's pelvic floor, can release tender points, and normalize overall tone of the pelvic floor. Education also plays a huge role in how we treat these conditions. So educating women and men about their anatomy and function of the pelvic floor. We can teach them how to control the activity of these muscles, as well as empower them to take an active role in their healing, which is a very common theme that both Kathie and Felicia and I talk about here. In addition to manual techniques, we can also use dilators, which are right here, and then an internal trigger point wand that you can see here. However, this is not always the first line of treatment and is always done based on the patient's comfort level. So we'll recommend what we think is clinically best, but it's always the patient's decision in the end. Excuse me. So teaching the proper use of dilators and wands can take several appointments, and it shouldn't be rushed. Rushing through these can have a negative effect on the prognosis of these conditions. In addition to everything we just talked about, we'll also screen for anxiety, depression, and trauma, and refer out if necessary to other providers that are also experts in that. The most important thing is that everybody that comes in gets a very individualized treatment.
Can we go back for 1 second? I wanted to add one thing. So I just want to let all of you know that if one of these things is what's happening to you, a lot of women I hear say, I just have sex, I'm going to go through with it, I'm not going to tell my husband that it's happening, and they just keep having sex with pain. And the problem is as Natalia was talking about the muscles, both Natalia and Felicia were talking about the muscles, those muscles, what they do is you don't even realize it, but when you're going to be intimate, and those muscles will tighten up so tight that for some women, it can almost feel like a wall. They're hitting a wall with sex. So I would highly recommend, if you're having pain with sex, to seek treatment, so that you don't want to keep doing that, because that can actually make that pain, those muscles contracting, even worse. And so I just wanted to interject that, because I just find so many women just kind of live with the pain, but we really, the combination of the pelvic floor physical therapist and the services that we do can really make that difference. And sometimes it can take a while. Like Natalia said, I tell people sometimes it can take a month from going from one dilator size to the next dilator size, but we really can make a difference. And the sooner we get to begin to work with you, the quicker the recovery usually is.
Mm-hmm. Yep. Thank you, Kathie. That was a good point.
Yeah, absolutely. All right. Constipation. Who has not had constipation in their life? So constipation can be in males, females. We've all pretty much experienced it at some time. So these are just some things that we kind of focus on a little bit specifically in pelvic floor physical therapy. Also, Kathie does some of these as well in her office. So behavioral components. Some examples can be as simple as water intake. A lot of the times we're just not drinking enough water, and that changes the consistency of your stool, making it harder to have a bowel movement. Diet as well Having a bowel voiding schedule can be something that can help you with constipation too. A squatty potty. So if you have never heard of a squatty potty, when you're done this, you're going to go on YouTube and look up their marketing commercial that they have. It is hilarious. It's a little unicorn literally pooping out rainbow ice cream. So you're going to do that for a little giggle. But squatty potties are actually really important. So if you see in the picture on your slide, this little like pink orange looking thing is called your pivorectalis muscle. That muscle is really important when it comes to having bowel movements. On a regular basis, every day, that muscle is kinking your rectum so that stool is not coming through when you're at rest. When you go to have a bowel movement, that muscle should lengthen and you should have full relaxation of your pelvic floor so that there's space for the stool to come through. So what a squatty potty does on the side here that says a squatting posture is it allows for optimal lengthening of that pivorectalis muscle so you can have a bowel movement with more ease and not strain. So straining with bowel movements is a big no-no that can lead to things such as prolapse that we talked about. It can lead to hemorrhoids, a whole list of things that you do not want to deal with, but it's just an example of something we can do here. Something else that we focus on is a variety of ways to do biofeedback so that you can be aware of your muscles regarding bowel movements. So we can retrain the internal anal sphincter with certain techniques that we have. We have a device here that we can do down training with your muscles so you're aware with audio and visual cues. There's all different kinds of feedback that you can get from that. We also, as we just talked about, we talk about mechanics and positioning for proper defecation, such as the squatty potty. We can do different abdominal manual therapy techniques, such as a abdominal massage to allow some assistance with moving your stool through your intestines. And something that's really, really important is having regular physical activity. Moving helps move your bowels, okay? And it's really, really good for your gut health and your overall health as well. So these are just some things that we focus on related to constipation.
All right, prolapse. So like any muscle in the body, it can be stretched, it can be strained, and it can be torn. When that happens, the organs that the pelvic floor muscles support can slip out of place. This can happen over time. Over time, all muscles can become weaker with age. It can happen from pregnancy and delivery. This puts extra strain on your muscles. Having a hysterectomy, going through menopause, having hormonal changes, and weight gain can also be risk factors for having a prolapse. So the symptoms typically depend on which organ has fallen out of place. But typically, I often hear from my patients that they see a bulge in their vagina. They may be leaking urine, things may feel weird during sex, or they may feel heaviness or pressure in that pelvic floor area. So Kegels are usually the first line of treatment. However, we want to make sure you're doing them correctly because like Felicia said, pressure management is so important when it comes to prolapse. Your PT can also help you understand how to perform these exercises and how many you should be doing per day. It's individualized for each patient, which is also very important. We'll also work on strengthening the core to help support the pelvic floor muscles. And when we talk about strengthening the core, we don't do sit-ups or crunches here. So that's another important reason why, if you feel like you are having a prolapse, why it's a good idea to see a pelvic floor PT to make sure that you're doing these exercises correctly. Behavioral techniques are also important, as well as speaking to your physician or Kathie regarding pessary use and hormonal treatment if PT is unsuccessful. PT does not work instantly. It takes time to build strength, so we have to be patient. But for many women, PT is a very effective conservative treatment for prolapse, which is highly recommended before surgery and other interventions.
Can I just interject something about the prolapse? You're done?
Yeah.
So Natalia is absolutely right. Strengthening those pelvic muscles can help, even if you're deciding, say you have a grade 4, which is something hanging out of the opening of the vagina. doing those exercises is going to promote a better surgical outcome. And when we talk about this prolapse, even though it's we talk about a cystocele or rectocele being a bladder or bowel, really the prolapse is changes in the vaginal wall. And so we need to strengthen or support that vaginal wall and the organs, the muscles around it. I just wanted to interject a little bit of about what a pessary is. A pessary is a device that goes in the vagina and can support the tissue up. So say you're working with pelvic floor physical therapy, but you have this bulge and it's there all the time and it's affecting whether you can be active. A pessary is a great temporary device. If you've ever used a diaphragm in the past, it's very similar to a diaphragm. It's fitted in the office. It's usually not uncomfortable. But the issue is there are many different types of pessaries, and we always try to start with the least or the easiest one to get in and out that you could be independent on. There are some pessaries that you can't get in and out independently. So I just wanted to throw that pessary component in there, and the real importance of doing exercises. Sometimes if you put a pessary in and then work with physical therapy to strengthen those muscles, there may even be a possibility. I can't tell you that I see it often, but there's a possibility to be able to take that pessary out and to be effective without needing that pessary by strengthening your pelvic muscles.
Mm-hmm. I usually tell my patients that pessaries are almost like an orthotic device. So
absolutely,
how you would insert something into your shoe to make your foot more comfortable when you're walking, that's similar to how a pessary will work internally.
I love that description.
Thank you.
Okay. All right, so postpartum. So the goal for postpartum women is to return to their pre-birth functional level. So some things that we can do to achieve this are to assess and treat diastasis recti, which if you look in the picture, all that basically means is the separation of your abdominal muscles. So over here, if you guys can see the laser, how these muscles are kind of close together. You'll see this like lighter shade in between there compared to the one on this side, how there's a large separation there. So that's called diastasis recti, and that can really impact pressure management, which can then impact your pelvic floor with all the things we basically just talked about, including prolapse. So we can assess that and work on that as well, a variety of ways that we can do that. We will also assess and treat stress versus urge urinary incontinence, making sure that your pelvic floor muscles are working optimally to prevent any kind of incontinence. So stress is more, again, that pressure management. Urge is more having increased frequency to urinate. Also, dyspareunia is on there. So same thing that we've been talking about, pain with sexual intimacy. We will assess those kinds of things as well, kind of repeating everything we said already. And then some things we can also do are review proper body mechanics, pressure management, like we said, and a big one is safe ways to return to your individual exercise routine. A lot of women postpartum tend to jump back into the routines they were doing previously. I have a lot of my patients who do the HIIT workouts, and that sometimes causes a whole list of issues, not only related to pelvic floor, but some other components as well. But basically just trying to get you back to the pre-birth functional level is something that we focus on here. Okay, so this is a slide so that you can contact all of us. The first one on the top is the number for Kathie and her Center for Incontinence and Pelvic Health. And then there's two numbers at the bottom for pelvic floor physical therapy. The first one is the number to our outpatient rehabilitation clinic. And the number on the other side is for central scheduling. So if you are cleared by your physician and they said, this is a great idea for you, you can call central scheduling to make an initial evaluation, and you will require a referral for that. And when we answer questions, we'll leave this slide up so that you guys can write these numbers down so that you have the information. Oh, you got it, Kathie. I think you're muted.
All right, yeah.
There you go.
So I wanted to introduce one other person, and Chelsea, I'm sorry, I can't remember your last name. I'm terrible with names in general. We also at Capital Health, we also have another program that is led by Chelsea, and she is a personal trainer that specializes in pelvic health. So we have two programs. Actually, you know what? I'm going to be quiet. Chelsea, go ahead, jump in.
Hi, everybody. Chelsea Wargo here. So we do offer throughout the year a number of different series where we focus on the pelvic floor from an exercise standpoint. I also offer a prenatal and postpartum workout. So if you saw that diastasis recti and you're like, I absolutely have that, the postnatal class will be incredible for you to regain that core control. We have a series actually starting on Tuesday. It's a 4-week series. We'll be focusing on adjusting those breathing mechanics, working on posture, the hip and spinal mobility, stability, and just also working on isolating those pelvic floor muscles to gain that full range of motion that you heard about through all of our lovely speakers this evening. It is a group class, so it is a bunch of you. Usually I have people come up to me after class and they're like, I'm dealing with this, and we have that private one-on-one interaction. And obviously, if there's something where you're not feeling it and you need that extra care, obviously, I send your information along to our PTs and to Kathie as well. So it's a great class that we offer. Again, it's starting on Tuesdays, this coming Tuesday, and then we'll be offering 2 different sessions in January, and those will be 6-week sessions.
And Chelsea, can you just address the postpartum and prenatal classes when that occurs?
Absolutely. So those are just ongoing classes. It's not set up as a specific series. You can come and go as your schedule permits. We have 3 different prenatal classes throughout the week: Monday evenings, Wednesday evenings, and Saturday mornings. And then we also offer a few different postpartum options. We just started offering a 4th trimester class, and that is for those 6 to 8 weeks postpartum, where you don't have that exercise clearance, but you still need to have that bit of a rehab of your core control of those pelvic floor muscles. And it just helps give you that head start to get your body back to where it needs to be. We also offer mommy and me classes on Saturday mornings. Those are very fun. Part of the class, you have your baby in your sling on you. We'll work on that posture. You know, a lot of us have that pelvic tilt when we have our babies on us. So we work on finding those adjustments to work on our posture, taking that pressure off of the pelvic floor. And the other half of class is just a bit of core work. Baby's just hanging out, and we all have a lot of fun. And then I also offer a strength and conditioning class for postpartum moms as well, and that is on Wednesday evenings.
Thanks, Chelsea.
Thank you.
I've had really positive feedback from my patients who have participated in Chelsea's programs. And it's a great way if you don't have insurance coverage for pelvic floor physical therapy or your time is limited. It really is a great option to at least get started with things.
Absolutely.
I've tried to answer a couple questions as Chelsea was talking in regards to referrals. You do not need a referral to see me. You can just call and make an appointment to see myself, or my partner's name is Jamie Kell. She's also a nurse practitioner. I'm also excited to say the Center for Incontinence and Pelvic Health is bringing on a urogynecologist starting in February. He has been in practice and just relocating, so that's an exciting thing from a surgical standpoint. I also wanted to add one thing. The physical therapists were talking about doing exercises postpartum. One of the things I hear in some of my postmenopausal patients is that, oh yeah, somebody taught me to do those Kegel exercises after delivery. And then I kind of stopped doing them. So my favorite saying is, every time you pee, think of me and do 5 exercises for the rest of your life. So I know we individualize how many exercises you should do. There are some research studies on how many need to be done, but as long as you're doing, you know, after you get that initial treatment and you have your regimen plan, you have to incorporate those exercises into everyday life. And hopefully you will all be peeing for the rest of your life. So therefore, if you connect the 2 together, it's a great combination.
I just want to piggyback real quick off of Kathie. For the referral for PT, it's great. Go to Kathie and get those referrals. But if for some reason you can't get a referral from her, you can get it from anybody. It can be from your primary care, things like that. We all just want you to get in for the proper treatment that you need. And I agree with Kathie with bringing exercises into your daily routine with all of this. I tell a lot of my patients, some of the exercises we teach you here, we're trying to make them efficient so they're not a chore for you. So we will find a way so you can incorporate them into your daily routine. So even if it's taking a few minutes of your time when you wake up in the morning or before bed, anything like that, this is going to be really, really important for you to have in your everyday routine. It might be for the rest of your life, literally, so that you don't have these issues. But we can't, reiterate how important it is to have these in your daily routine.
Yes, and just to interject about the referrals for pelvic floor physical therapy, if you're talking to your primary care physician or your gynecologist, and they're going to send you for physical therapy, ask them to make sure they say pelvic floor physical therapy, because sometimes if you think, oh, well, I live in New Jersey, South Jersey, I can't come up to Capitol for physical therapy, but you're going to go to another location. Not all places have pelvic floor physical therapists. So you want to make sure that's who you're connected with. And like they had said, we have 3 wonderful pelvic floor physical therapists. I gotta toot their horn. They do a great job. My patients love them. We see great outcomes with the patients that they're seeing. Or the individuals that they're seeing. So just keep that in mind as you're looking to go and see a physical therapist.
Absolutely. All right.
Chelsea, can you answer? There's a question here in regards to how can they locate it. I know I have a phone number to register for the classes, and I can read that all to you. I'm expecting a new moms. The phone number I have here is 609-537-7243. And you know what? I can add this into the screen. The online, it's wellnessliving.com. Oh, did somebody put it in there? Oh, I'll put it in there.
I'll put the link up.
Oh, thanks, Chelsea, because I'm reading it. That's wonderful. Are there any questions at this point? If you want to unmute yourself and do a question, that's fine, or you can type it in the chat box.
I just wanted to say thank you. You did a wonderful job, all of you, and also to thank everyone for coming. I just put the recording link back in the chat box for people. Like I said, it'll probably be a week before you can go into it. And then I'm just retyping now the evaluation. And again, I would really appreciate it if you fill out the evaluation. Not only do we want to hear what you thought of the program, we also will get suggestions. You can give us suggestions for future programs that you would like to see. Were there any other questions that, Kathie, that and the group that you would like to answer? I think you pretty much got them all. I don't know if you want to review, like people were asking what kind of soap to use and all that. I didn't know if you wanted to read through for the general group or.
Yeah, I did put some of those on there. I put some detergents, and I also talked about soap.
Okay. Yeah, that's fine. So people can see that if they would like.
So that's a great question in regards to the gynecologists do the same thing that we do at the Center for Incontinence and Pelvic Health. Well, some, yes, a lot of them don't. A lot of them will just refer to us, because when you're going to your gynecologist, maybe for your annual exam, they're focusing on that annual exam and those issues. So when you come to see me, for example, your initial appointment is for an hour. We're going through all of those potential, your history, and then the exam is focused on that external tissue, internal tissue, any other issues that can be going on.
I agree with you, Kathie.
Oh, and I do want to say probably my number one referrer to sending patients to me is the gynecologist. So yeah. Any other questions?
If not, I just want to let people also know that I'm going to hang around for a little bit. So you have some time now if you'd like to fill out the evaluation and get it in. So I'll be here probably like another 10 minutes. I guess if all the questions have been answered, the speakers can leave if you like to, unless there's something that you would add. Again, I really thank you for doing a wonderful job.
Thank you.
Thank you. I think, Sherry, did you have a question? I saw you raise your hand.
Yeah, maybe a couple. I wanted to know about insurance. Does the center accept most insurances?
Yeah, we do. We accept probably the same insurances that, well, not the same, but yeah, Most insurances we accept. So when you would call to make an appointment, they'll make sure that it's covered. And it's usually a covered service by your insurance.
Yeah. Same for
Okay.
physical therapy.
And I just want to add that I was in one of Chelsea's exercise classes just this afternoon. This was a class for seniors in the Healthy Living Program, and she is great. She's terrific.
Awesome.
Hi, Chelsea.
You.
I guess I just
There.
want to add that I always like to say is please don't live with whatever. If you are having an issue, please don't just live with it. So many people say, you know, I've lived with this when they come in to see me for 10 years, 5 years, 2 years. And to me, we can often make things better, make a significant change in your quality of life in regards to intimacy or bladder, bowel function, all of those things. And that team approach between myself, Chelsea, Natalia, Felicia, and Shayna is another pelvic floor physical therapist. You haven't seen her on the screen there, but she's also an active pelvic floor physical therapist at Capital. It just don't live with it.
Yeah, going off of Kathie, these conditions that we talked about and the other ones that Felicia had mentioned, they are common, more common than you would think, but they're not normal. And all of us here treat very holistically, very passionately, and we just want to help you all get better. And again, everything is always geared from you. You have to be comfortable with everything that we do. So we just want to empower you to take that active role in your healing so that, you know, you can live healthily.
So someone asked if pelvic floor therapy is only available at the Hopewell location. Right now, we are only set up for it at the Hopewell location, but if you're having issues with transportation or anything like that, we can try to assist you with that as well.
Yeah, and the Center for Incontinence and Pelvic Health, we have 2 locations, one in Newtown, PA, and one in Lawrenceville.